Welcome. Today we're diving into the world of kidney health to understand a condition called reflux nephropathy. Reflux nephropathy, also known as chronic pyelonephritis associated with vesicoureteral reflux, is a kidney disease characterized by scarring of the renal tissue. This scarring results from recurrent urinary tract infections in childhood, coupled with a backward flow of urine from the bladder into the ureters and kidneys, a condition called vesicoureteral reflux or VUR. Let's unravel the complexities of this condition, exploring its causes, symptoms, diagnosis, and treatment. At the heart of reflux nephropathy lies vesicoureteral reflux, or VUR. This occurs when the valve mechanism where the ureters connect to the bladder malfunctions. Normally, this valve prevents urine from flowing back up the ureters toward the kidneys. When VUR is present, urine can reflux, especially during urination. While VUR itself is often congenital, meaning it's present at birth, the real damage occurs when this refluxed urine is infected. Bacteria from the bladder can travel up to the kidneys, leading to repeated infections and inflammation. Over time, these repeated infections and inflammation lead to the scarring that defines reflux nephropathy. In some rarer cases, secondary VUR can develop due to obstructions in the bladder or urethra, leading to increased pressure and reflux. Let's delve into the pathophysiology. With VUR present, infected urine ascends into the renal parenchyma, the functional tissue of the kidney. The bacteria trigger an inflammatory response. White blood cells rush to the site of infection, releasing chemicals that fight the bacteria but also damage the delicate kidney tissue. This repeated cycle of infection, inflammation, and damage leads to the formation of scar tissue. This scarring, particularly in the renal poles, distorts the kidney's structure and impairs its ability to filter waste products from the blood effectively. The damaged nephrons, the kidney's filtering units, are unable to function properly, leading to a decline in overall kidney function. In advanced stages, this can progress to chronic kidney disease and even kidney failure. Reflux nephropathy primarily affects children, particularly infants and young children, because they are more prone to VUR and urinary tract infections. Prevalence rates vary across different populations. Studies estimate that VUR is present in around 1–3% of children. However, the development of reflux nephropathy depends on the severity of the VUR and the frequency of UTIs. Girls are more susceptible to UTIs than boys due to anatomical differences, making them somewhat more prone to developing reflux nephropathy. Early diagnosis and treatment of VUR are crucial to prevent the progression to reflux nephropathy, so screening practices can heavily influence the observed prevalence. In the early stages, reflux nephropathy might not cause any noticeable symptoms. This is why early detection is so important. As the condition progresses and kidney function declines, various signs and symptoms can emerge. Common symptoms include recurrent urinary tract infections, often with fever, flank pain or vomiting. High blood pressure can develop as the kidneys lose their ability to regulate blood volume and blood pressure. Proteinuria, the presence of protein in the urine, is another sign of kidney damage. Children might experience poor growth or failure to thrive. In advanced cases, symptoms of chronic kidney disease like fatigue, swelling, and changes in urination patterns become apparent. Diagnosing reflux neuropathy involves a combination of imaging and laboratory tests. Avoiding cystoarthrogram, or VCU, is the gold standard for diagnosing VUR. This involves inserting a catheter into the bladder, filling it with contrast dye, and taking as rakes while the patient urinates. This allows doctors to visualize the flow of urine and identify any reflux. Renal ultrasound is often used as an initial screening test to assess the size and shape of the kidneys and detect any structural abnormalities. A DMSA scan, or dimercaptosuccinic acid scan, is a nuclear medicine test that can detect areas of scarring within the kidneys. Urine analysis helps identify signs of infection and proteinuria. Blood tests assess kidney function, measuring creatinine and BUN levels. A history of recurrent UTIs, especially in childhood, is a critical piece of the diagnostic puzzle. While reflux nephropathy itself isn't typically divided into strict types, VUR, the underlying cause, is graded based on the severity of reflux. The International Reflux Study Committee has established a grading system from grade I to grade V. Grade I involves reflux into the ureter only, without dilation. Grade V is the most severe, with significant dilation of the ureter and renal pelvis, as well as blunting of the renal calyces. The higher the grade of VUR, the greater the risk of developing reflux nephropathy. The primary goal of treatment is to prevent further kidney damage and manage complications. Antibiotics are used to treat and prevent urinary tract infections. Prophylactic antibiotics, given daily, can help reduce the frequency of UTIs in children with VUR. Surgical intervention, such as ureteral reimplantation, may be necessary in severe cases of VUR to correct the valve defect and prevent reflux. Blood pressure control is crucial to protect the kidneys from further damage. AACE inhibitors or ARBs are often used to lower blood pressure and reduce proteinuria. Dietary modifications such as limiting sodium and protein intake can help manage kidney disease progression. In advanced stages, dialysis or kidney transplantation may be required to sustain life. Regular monitoring of kidney function is essential to track the progression of the disease and adjust treatment accordingly. Preventing reflux nephropathy starts with early detection and management of VUR. Screening for VUR is recommended in children with a history of recurrent UTIs or those with a family history of VUR. Prompt treatment of UTAs is crucial to prevent them from reaching the kidneys. Proper hygiene practices, such as wiping from front to back after using the toilet, can help reduce the risk of UTs. Encouraging frequent urination and complete bladder emptying can also help prevent UTAs. Circumcision in males has been shown to reduce the risk of UTAs in infancy. Educating parents about the signs and symptoms of UTIs is vital for early detection and treatment. The prognosis for reflux nephropathy varies depending on the severity of the condition, the age of diagnosis, and the effectiveness of treatment. Early diagnosis and management of VUR can significantly improve the prognosis and prevent progression to chronic kidney disease. However, even with treatment, some individuals may still develop kidney damage and require long-term management. Recent research focuses on identifying genetic factors that contribute to VUR and reflux nephropathy. Understanding these genetic predispositions could lead to more targeted screening and preventative strategies. Researchers are also exploring new therapies to reduce inflammation and scarring in the kidneys. Minimally invasive surgical techniques for retinal reimplantation are also being developed to reduce recovery time and complications. Gene therapy and regenerative medicine hold future promise for repairing damaged kidney tissue. Further research is crucial to improve outcomes for individuals with reflux nephropathy.